I'm Julie O'Connor. I'm a clinician and a researcher. I've been here at Kennedy for the last 30 years with the neurobehavioral unit programs. We have a continuum of care with an inpatient unit. With an inpatient unit that serves about 16 children with severe behavior problems and neurodevelopmental disabilities. And we also have outpatient services. And I am the associate director for the outpatient program, where we have day treatment services and intensive outpatient programs. We work with all children that have severe self-injurious, aggressive, disruptive behaviors who also have neurodevelopmental disorders. So while by diagnosis, I haven't necessarily treated a child with an ASXL related disorder, I am very confident that over the 30 years that some of those kids probably did have this genetic change. And hopefully over time, we'll be able to see more of those types of kids. But can I move to this one? Perfect. And as I mentioned, I'm a clinician and a researcher. So our program serves individuals from the age of 10 months up to 66 in our outpatient program. It doesn't have to be a child, but I may refer to individuals as children because they're all kind of our kids. So what I'd like to do today is just first go over an overview of some of the behavioral issues that we commonly see in ASXL related disorders. Then review some of the potential environmental factors that may be playing a role in challenging behaviors, and explore various treatment options. I want to start off by saying that the answers are not quick or easy. Problem behavior is not a disease that has one trajectory. So it's not like going to your pediatrician and getting a strep culture and saying, oh, you have strep throat, take this antibiotic, go home, you're fine. It's not that simple. It's not that straightforward. There's not one trajectory for all of us. And the assessment process does take time. We need to understand as much as we can about the behavior and under what conditions the behaviors are happening, under what environmental factors they're happening, before we develop treatments on ways to intervene. And then that treatment evaluation is also going to take time. So first, I'm going to review some of the most common behavioral issues that have been identified. And I am definitely borrowing from the slides from the foundation website as we go through each one. I will say that through the focus groups this weekend, I'll be able to add additional behaviors that people have mentioned and commented on across the three different syndromes. So with ASXL1, very commonly see diagnoses along the lines of autism, behavioral disturbance, self-injurious behaviors, repetitive behaviors, and also a pleasant demeanor. So you will see that these are very much related to that Venn diagram that's on the website. In ASXL2, we see behavioral disturbances as well, in addition to hyperactivity and aggressive behaviors. ASXL3 has a wider range of behaviors that have so far been identified. Autism or autistic traits, behavior disturbance, self-injury, specifically noted were face slapping, head banging, and self-biting, aggressive behaviors, repetitive movements, hand flapping, obsessive compulsive behaviors, and that was one that came out a lot yesterday and Friday as we had our focus groups. Poor eye contact, other maladaptive behaviors, anxiety, which I will say that anxiety looks different for every one of us. So I often am I will question you when you say it's because of anxiety, because I want to know what that looks like. Anxiety for each one of our kids looks different. Anxiety for me looks different than it does for someone else. So if you were sitting next to me before I presented, you would have noted that I was very much tapping my foot as I was getting more and more anxious. I got up and I walked out and I took a little walk to help relieve my own anxiety. But it looks different for me than it's going to look for each of your kids. So I'm going to ask you, tell me what that means for you. What does that mean for your child when you say anxiety? One of the studies that has been done with ASXL3 that's been published that outlines some of the behavioral characteristics was published in 2021. And they looked at 7 cases that were retrospective study, meaning they went back into the records and they retrospectively evaluated what they saw, the content of the records for these kids. And they identified disruptive behaviors in about 57% of those cases, as well as aggressive behaviors, and autism or autistic-like traits, ADHD and SIB. The diagnosis of the autism spectrum disorder, I've seen in different studies anywhere from 30% of the population to this study that showed 43%, up to 50%, others showing a little different. So I'm very hopeful that as we continue to do the studies and having families participate, especially with some of the ALP study, the focus groups from today, we'll get a better characteristic and maybe be able to hopefully come up with a better percentage rate of what we're seeing in all of these types of behaviors, but autism in particular would be one to take a look at. The autism traits that were identified were things like poor eye contact, hand flapping, rocking, very much stereotypic types of behaviors. So now that we've identified that the three different ASXL related disorders have different presentations of behaviors, what are we going to do about problem behaviors? And while it sounds really simple, let's just tell me what to do. What should I do? Well, it's really going to depend. And it's going to depend on a lot of different factors. Many of you brought up concerns about medical conditions, pain, other medical problems that may be eliciting behaviors. So those are some of the first factors that as a psychologist, I'm going to ask you about. Even in my initial evaluation, I'm going to talk to you more about, well, what are some of the medical concerns that you have? Have you met with eye doctors? Have you met with GI specialists? What has already been done? Documenting everything that's been already rolled out, but also making sure that we can collaborate together. And if there's a medical professional I need to be talking to who's related and helping you problem solve the different pain-related or medical-related challenges. It's very helpful from my perspective so that I'm not trying to develop a behavior plan that is absolutely something that needs to be addressed first with a medical component. In addition, for those individuals who do display self-injurious behavior, we're going to take a lot of safety precautions here. Self-injury, especially head-directed self-injury or eye-directed self-injury, I'm going to want to make sure that you've already had that evaluated by medical professionals. A vision exam, head-directed self-injury, whether it's head banging or head hitting, we're going to worry about the eye and the retina, and we're going to worry about things. And we're going to want to make sure a good evaluation is conducted. And I know how challenging that is. We're lucky here in Baltimore with Hopkins. They have the Wilmer Eye Institute, and they are ones that absolutely collaborate with us, with our kids with more severe challenging behaviors, and are able to do ophthalmological exams and look at the retina to make sure the retina hasn't been detached or anything like that, because we're going to want to make sure that the child's being kept safe that way. While we're doing behavioral assessments, we may also take some other safety precautions, and that might be adding in protective equipment for those individuals. And I heard this a little bit over the course of the last couple of days, engage in self-biting. We have some kids that might bite their hand or their arm, which could lead to callousing or bruising or lead to infections because it's an open wound. It's going to be very important to maintain the skin integrity. So it may be that we may suggest while we're doing an assessment, let's make sure we're keeping that area safe. It's not getting any further damage. Maybe there's gloves or some other form of safety equipment that we might recommend. We also will modify a lot of equipment. I have some individuals who engage in pretty significant self-injury, and they may have shin guards or padding on their legs, like what do you call it, football pants that have padding. So we get very creative in making sure we're keeping the child safe and protecting from injury when we're doing any of these assessments. So the assessment process. We want to figure out why the child is engaging in problem behavior. Why is the function, and that's what I'll refer to it as, the function of behavior so important? And it's important to us because if we misunderstand and we get the function wrong, we're going to likely have the wrong treatment. So for example, if a child is looking to get a reaction and providing that reprimand or yelling and saying, no, don't do that, is that reaction, that's going to increase the behavior. So that isn't going to be effective. Telling them no might not be effective because they may be looking for that reaction. Or a timeout. Oftentimes you'll hear, you put the child in timeout, take them away from those stimuli. But if they're looking to avoid academic demands, for example, it's going to increase the likelihood that they will use that behavior to escape the work. So if you use timeout, you're actually reinforcing the problem behavior, and it's likely to continue and be maintained. So for example, I had an individual who in their classroom setting was having disruptive behaviors. And when they would have disruptive behaviors, the teacher would have them go sit in the hall. Well, it kept increasing and the teacher couldn't understand that. And I'm like, well, does he ever have to do the work that was happening in the classroom at that time? Well, no, we just don't make him do it. When he calms down out in the hallway, he comes back and he gets to have a break and he gets to do something different. And I said, well, he learned that he could escape that particular task and just sat in the hallway. And that was probably what he was looking for. I don't want to do that. So we have to be mindful of why things are happening and what the functions of behavior are so that we don't inadvertently suggest the wrong type of treatment. Function-based treatments are something that are widely evaluated in the work that I do. And this is just a summary slide of various research studies that have been published looking at behavioral treatments to assess and treat severe problem behaviors, such as self-injury, aggression, property destruction, and the like, all with individuals with neurodevelopmental disabilities. This has been done in outpatient clinics, inpatient units, residential programs, in individuals' homes, as well as by telehealth. And I realized my reference isn't listed there for telehealth, so I'm going to have to add that to the slide. So we know that function-based treatments can be very effective. In the clinic that I work in, when we analyze our data from and this is pre-pandemic data, I have to reanalyze for pandemic data, but for the 5 years prior to the pandemic, our outpatient service in our day treatment and intensive outpatient, we were able to reduce problem behavior in 86% of our kids by at least an 80% reduction. And that's really, really good. So function-based treatments can work. I will say, and I will share and be very open with you, the most challenging kids we have within our clinics are those kids that have both the challenging behavior, neurodevelopmental disabilities, but in particular, kids with more rare genetic disorders. So what does that tell me? Services for those kids are going to take a little bit longer, and they may be more comprehensive treatment evaluations that we have to do. So these are some of the most common factors that influence problem behavior. Kids engage in problem behaviors, one, to get attention. Whether it's positive or negative attention, it doesn't make a difference. Being told no or people attending or a big reaction often is associated with increases in challenging behaviors. Gaining access to their preferred items, such as an iPad or a movie or a telephone. Escaping a demand, like I mentioned earlier. Also self-stimulation, meaning it's more internally driven. So those are going to have different treatment options there. Anxiety is one of the most common factors that families will highlight. And then communication. And by that, I mean that children that do not have the ability to communicate as effectively as we would like often we're seeing that they're engaging in problem behaviors to communicate their wants or needs. And that's an area that we really need to focus on so we can improve the communication strategies that they have available to them. So how do we do this? And within our programs, we use applied behavior analysis. So many of you are going to have heard of that if you have a child who's diagnosed with an autism spectrum disorder, because ABA is one of the treatment strategies that is approved and is identified as an appropriate treatment for autism. But I'm going to tell you, it's not just kids with autism. It's very frustrating that insurance companies only are only required to provide ABA for individuals with that diagnosis, but ABA can be applied to any individual, typically developing as well as, but any type of neurodevelopmental disability. Our goals are to do a few things. One is to increase appropriate and adaptive skills. I look at it from a perspective that all of us need some level of reinforcement in our environment. One of the things we want to do is eliminate the reinforcement for the challenging behavior. But to do that, I need to increase the reinforcement for other things. So let's just say my baseline, I need this much reinforcement. Well, if I just remove reinforcement for the challenging behavior, I'm only getting this amount. Well, I still need this amount. So I start off by saying we need to increase appropriate skills, increase reinforcement so that we're not dropping the level of reinforcement, but now we can take away that reinforcement for the challenging behavior. So we're not seeing an overall dip. Hopefully that makes a little sense. But I like to increase all that reinforcement available to the child so that we can then take away the reinforcement that's happening for the problem behavior. So oftentimes we'll be increasing communication, increasing social skills, increasing leisure skills, which I know for many of our individuals, having leisure skills and social skills is a big challenge. So we really have to focus on how do we get those skills increased. We also want to see if we can alter antecedents to those problem behaviors. So for example, oftentimes entering an environment that is a big room like this, where there's lots of sounds and noises and people, oftentimes that is very, very distressing for individuals with neurodevelopmental disabilities. So what do I want to do? I want to see what can we do to change that? Well, I might suggest, well, before you enter that environment, put on noise canceling headphones, something like that, so that they're not going to be exposed to that loud noise or those echoes that are happening in a room that this size. And then the last part of what we do is then weaken those consequences for problem behavior. Again, we need to know what those consequences are that are keeping it going. So that's why the functional assessment process is so valuable. So with the functional behavior assessment, we're looking at developing hypotheses as to why the behavior is happening, what the function of behavior is. And that way we are able to develop a treatment specifically related to that function, and that we can then have the child gaining access to that reinforcement for the appropriate skill to get that function met. We first have to define our behaviors very clearly, and these need to be behaviors that are observable so we can take data on it. You will find out I'm very data-based. Everything we do, we take data on about everything. And we specify what those behaviors are. What exactly is aggression for your child? What exactly is self-injury for your child? And I would do the same if it were anxiety. What does that look like for your child? Then we start our functional behavior assessment, which can be an indirect assessment, meaning we're collecting information by interviews and questionnaires. And then we're going to do some direct observation to make sure we're seeing the same types of behaviors. Some of the types of functional assessment questions that I like to ask, and if you have a behavior analyst or a psychologist who's behaviorally trained, they're going to ask a lot of these types of questions. For me, it's just as important to know when the behavior always occurs, but also when does it never occur? That's going to lead me to some ideas about what treatments could look like. It never occurs if they're on the iPad. Awesome. That can be a reinforcer for us. But that's also a challenge because it means I have to limit their access to certain times. So limiting access to preferred things then allows that reinforcer to be more meaningful. We're going to ask questions like what happens before, what happens after. What do you think the individual is trying to communicate with you? Do they seem to be wanting a reaction? I know I heard someone in one of the focus groups say, they'll look right at me and throw it. Like, okay, they were looking for that reaction just to see. And I should say throwing was something that came up a lot yesterday. That falls under kind of our disruptive behaviors, but I did hear a lot of throwing throughout the focus groups. Does the individual seem to have the behavior when they need to wait for something? When you're transitioning from a preferred activity to a non-preferred activity or any transition? And does the behavior seem to happen in a very repetitive fashion? And that leads us to some suggestions about maybe internally driven and what we call self-stimulatory types of behavior. Oftentimes within a functional assessment, you're going to hear people talk about the ABCs, the antecedents, the behaviors, and the consequences. And those are the factors that I look at very carefully to see what happened before. So in this example, it was schoolwork was presented. What happened? What was the behavior? The child hit the teacher. And what was the consequence? The child was told, don't do that, or no, you don't have to do this anymore. And so that gives me an idea of what happened before and after and what I can manipulate in the environment as part of their treatment. This might be a sample of a data sheet that you might be asked to do as a parent if you're working with a behavior analyst, filling out what happened before, what happened after. because these are the types of things that we can then use to develop the treatment. In addition to just that immediate antecedent, I'm also going to be asking you about things that happened a little bit before that. So were they already tired? Were they already hungry? Was there, a particular event that had occurred recently that might be setting the stage for more problem behavior? We had a child who some days at school would do just fine when they would go in, do their morning routine, go right into work, no problem. And other days, they would have a lot of self-injury. And so we started to look at the team members in the classroom were doing the exact same things every day, but there was some other variable. So we started asking about, well, what was happening on their way to school? And what we identified was that it was just a difference in which caregiver was putting the child on the bus. And sometimes if it was mom, it would go smoothly, but if it was dad, it didn't go as smoothly. So we really started to have to tease apart, well, what was happening there then? So not that immediate antecedent, but something a little bit distal that was then impacting their ability to kind of just smoothly transition to their day. I mentioned functional behavior assessment. A very specific type of functional behavior assessment is called a functional analysis. And this is something that if you go to a program that's more similar to what we do in our clinic, in our inpatient unit, a functional analysis, it's one of the most researched approaches to assessment and treatment of problem behavior, but really only needed in the cases where a traditional functional behavior assessment wasn't able to identify the functions of behavior or that the treatment didn't work. So we need to do something more systematic. And so this is much more a heavily researched way of doing a functional behavior assessment, where we actually manipulate those environmental factors to come up with what the functions are. So once we figure out the function based on the functional behavior assessment or functional analysis, what are we going to do next? Well, we use those results to develop a very specific treatment for your child that's individualized. And I suggest always starting with one treatment component at a time so that you can evaluate if that treatment component is effective. If it's not, we're going to not do that one. Let's try something different. But if it is effective or partially effective, then we know that we can add another component that might help decrease the behaviors further. So overall, our goals are to increase appropriate adaptive skills, those replacement behaviors. We do this by identifying what's appropriate reinforcement for your child. And I will tell you that reinforcers for one kid are not the same as another. So when you go into a classroom and everybody's getting goldfish, I'm going to tell you they don't know what they're doing with reinforcement because goldfish might not be reinforcing. So I can say for me, if you were to give me Reese's peanut butter cups, I would absolutely not continue to present because I am highly allergic to that peanut butter and I would just go sit in the back. But if you were to give me caramel, I would stand up here and keep going. So it's very different. And so that's just a very exaggerated view of why it's so important to identify the reinforcers specifically for individuals. We all really do we do things because they're reinforcing to us. It increases the likelihood that we're going to continue to do it. Your team may do preference assessments, which are those strategies that are used to identify what's preferred for that child.
Sorry, I didn't mean to. I didn't mean to.
Common treatment components are going to be redirection, planned ignoring, treating replacement behaviors, and differential reinforcement. I'm going to go through these slides hopefully quickly, and prompting procedures. So redirection is simply redirecting to a different activity or a different task and praising the child for then engaging in that other activity. And I will say, when I describe these, they sound so simple. They are really hard. None of these are easy things to do, and it takes practice. Extinction or planned ignoring is not attending or not allowing escape for the problem behavior, depending on what the function was, and continuing with the activity that was at hand. So instead of allowing the child to escape doing that work activity, you're going to block the behavior, not attend to it, and just complete that activity with them. There are challenges to extinction because there could be an increase in the behavior before it decreases, which is called an extinction burst and very much expected.
I'm sorry, Mama.
So this is why I say it's so important to make sure we're reinforcing other behaviors, because we can help decrease that extinction burst if we have other things we're reinforcing. So what this might look like in the real world would be that if the child is trying to get that reaction from you, it might be that you're going to not attend. You're going to block the behavior so that he's not getting hurt, you're not getting hurt, and keep moving on. If the child wants to get out of something, again, not attending to the behavior, but keep going with what's on your schedule. If the child wants to have something that they cannot have, you can let them know calmly, no, it's not available, and allow them access to some other things that might not be as preferred. And keeping them busy and active in something else.
What happens
If it's a behavior that's happening for more internally driven that you really think is more sensory stimulation, we do try to prevent that. Often other ways of gaining access to that sensory stimulation in alternative ways. And you may be putting that onto a set schedule so that they're able to get that sensory input in an appropriate fashion, but at other times, as opposed to giving them access to the sensory item at that moment when the behaviors are happening. We're going to teach appropriate skills. One of the things that we do a lot is teach functional communication, which means teaching them an appropriate way to communicate for the item or the attention that they're asking for. This can be pictures, it can be voice output, it can be a communication device, but allowing them a way to ask for what they're wanting in an appropriate fashion. Similar to access to preferred items, teaching them to communicate appropriately for that item, and also providing them access to alternative items. With escape maintain behavior, meaning they're doing it to get out of work, providing follow through on that demand, while also allowing them the ability to ask for a break or ask for help, because those are two of the strategies that we think will be playing a factor, that they're not sure how to do the activity, they're not sure how to do that task, so they need help doing it, or that they need a break from continued work. There are also various schedules of attention, and I'm going to skip through these. Scheduling attention on different schedules of reinforcement can be very, very helpful. You're either going to provide attention for alternative behaviors, incompatible behaviors, meaning you found a behavior that they can't do both those things at once. So for example, you can't hand flap and sit on your hands at the same time. So reinforce putting their hands in their pockets or sitting on their hands. I have a lot of kids that if they in the hallways are like grabbing at stuff, we'll teach them to put their hands in their pockets so that you can't grab. And while you're walking down the hallway, you're saying, great job keeping your hands in your pockets. And that way they're not grabbing all the things that are happening in the hallway. So I'm going to skip the more descriptive slides because I realize what time it is. The last strategy on here that's listed, the prompting procedures, that's really a mechanism to prompt a child through a task demand. What I will tell you for the very beginning, I recommend to parents in particular that if you don't think you can follow through on a demand, don't place that demand. So I'd rather see you ask your child to do one thing and follow through on it than ask them to do 15 and not follow through on them. It's more important for them to start to understand that when you're asked to do something that you expect them to do it, but if you're not going to be able to follow through, then just don't place that demand. You really want to see that they understand that when a demand is placed and that you're really asking them to do something, you want them to follow through on it. The physiological or self-stimulatory behaviors. So these are ones that are more internally driven. They're not maintained by these external reinforcers that I mentioned. These are treatments that you're going to want to look at from a perspective of identifying what that sensory input is that they're looking for, providing that sensory input in a different fashion, and also providing that sensory input more on a schedule as opposed to giving them access to a highly preferred item contingent on problem behavior. Protective equipment I mentioned early on is something we use to make sure we're able to do the assessment process safely. But there are some individuals that we do utilize protective equipment for to maintain that the skin integrity and keep them safe. All I suggest with that is that we try to come up with a fading plan so that we can decrease the amount of protective equipment needed, but always keeping in mind we want to keep them safe first and foremost. Medications. I am not an MD. I am a PhD. So what I say about medications is many of the medications that are prescribed for the symptoms that are being presented, but there's not a specific medication that's been identified just to treat self-injury or aggression. There's not a one-way path there either. So I suggest consulting with a psychiatrist who has experience in ASXL related disorders or one who has experience with neurodevelopmental disabilities. Certainly, there are doctors that are willing to consult with local providers. And so oftentimes I have psychiatrists here at Kennedy who will consult with a local provider for a family that I work with out of state. And then they are able to maintain that contact and help them work through that process of identifying appropriate medication. Most likely outcomes are going to be that there's a combination of behavioral treatments, communication training, medication, and maybe protective equipment if that's needed. I will say two slides on schools, which is work with your school. If your child's behaviors are interfering with their ability to meet their IEP goals, IDEA, which is the federal law, requires that schools conduct functional behavior assessments anytime that the behavior is interfering with their making those gains. If your school is giving you some challenges with that, there are a lot of great educational advocates out there who can help you with that process. When the school has conducted a functional behavior assessment, if they identify specific variables, they should then be developing a behavior intervention plan, which they monitor over time and make adjustments to. And there should be someone within your school district who is a BCBA who would be overseeing that and making changes and monitoring it. So you should see data, you should see graphs, you should be able to see all that information. And these should be reviewed annually. You should get quarterly progress reports. If the behavior is not improving, they should be making adjustments. The behavior plans need to have measurable data attached to them, and they need to be routinely evaluated for their effectiveness. I suggest really connecting with your schools. You are the expert on your child. I may know a lot about behavior, but I'm not the expert on your child. You are. You know so much about that child that you can provide that information to the schools and help them better formulate the functional behavior assessment and develop that BIP. If you are looking for behavioral services, I recommend when you have insurance carriers, request what's called a special needs case manager. Your insurance company is not going to tell you they exist, but they do. And that allows you, instead of having to call your insurance company and say, hi, I need services for my child, and then you have to spend the next 20 minutes describing your child, a special needs case manager is someone who is identified, who can work directly with you. And that way you don't have to give your spiel and your 20-minute talk about all the things that are going on with your child. So I recommend that. And like I said, your insurance company is not going to tell you they exist, but they do. We utilize that a lot because we do need to go through a lot of insurance authorization for the services we provide. ABA services are available through insurance for kids with a diagnosis of autism. It's a little harder when they don't have that diagnosis. But for some other disorders that I work with, I have been able to help support the family getting ABA services by writing letters and supporting how this particular syndrome is highly associated with autism and autism characteristics, and why ABA would be an important way to get that. So my conclusions. Monitor any of your kids for the development of problem behaviors. Conduct behavioral assessments. Identify a behavior analyst or a behavioral psychologist who can help you work on developing strategies. You should be an active component of the assessment and treatment process. If your BCBA isn't incorporating you into that, then ask them to be incorporated, because you are absolutely know your child the best, and you should be a part of that assessment process. Within our program, the caregiver is required to be at the day treatment appointments. Our day treatment service is 2 hours twice a week, average of 16 weeks. Caregivers are part of that. They are there every minute of those times, and you're actively participating in the assessments. Same with our intensive outpatient service, which is 5 hours a day, 5 days a week. The caregiver is a part of that, and we train the caregivers to implement all the behavior plans as well. So make sure you're evaluating strategies to increase behaviors and decrease behaviors, taking data, and it really is possible to decrease problem behaviors. This is not on my slide, but based on my focus groups from the last 2 days, it's also going to be a very important component for you as a caregiver to have supports. So seeking out your own services to make sure you have adequate supports to be able to continue conducting these types of treatments at home. It's a lot of work. I know what I said. I told you it sounds simple. It's really not. It's very hard, and you're there 24/7. So please make sure you're getting the adequate support that you need. I listed here my email address. I also have business cards I can give you. I am really good with email. I am terrible with the telephone. I'm not good with the telephone. I also listed the website for BCBAs. So that if you are looking to get a board certified behavior analyst, they do have a link on their webpage for certificates. Or you can find a licensed psychologist who has experience in the assessment and treatment of behavior problems. So I want to thank you all. I really appreciate all the support from the foundation and all of the work that Natasha and all the team members are doing. It's been great to get to meet so many families. I'm really looking forward to continuing with the ALP study. I think I have some interviews with some families coming up over the course of the next 2 months. And I'm really looking forward to helping identify what those behavioral services will look like for your kids.
Thank you so much. It was a great talk. We have some questions coming in on the Slido, so feel free to add yours. One of the questions here is from a parent who has a 1.5-year-old with ASXL3, tracheostomy, mechanically ventilated, hypotonia, and the challenge is understanding what she needs because she's nonverbal. Aside from moving from her eyes, like any advice on how they can communicate with her. So I think generally trying to manage behaviors for someone who's nonverbal and has significant mobility and other medical challenges.
So yeah, and a little one at that, I mean, very young. So we oftentimes will start teaching very easy, simple communication ways, whether it's teaching through handing over a card or teaching us a sign. A lot of times with 1.5-year-olds, you might see kids start to learn more or help. Please, sorry, I didn't do help. Help is the difference. Need 2 hands. So teaching some sign language might be one strategy. I would say working with somebody who is speech and language therapist who can help identify some of those communication strategies to help them express themselves. As far as a parent communicating, I always suggest using very simplified terms, but also possibly having objects or pictures of those objects, depending on the visual stimulation and visual acuity. I often do a lot of object manipulation. So let's just say you're wanting your child to be able to say they need to diaper change or they need to go to the bathroom. The diaper change may be that they pick up the diaper and hand it to you, or they point to it on a screen. So finding ways to communicate, but I absolutely think a speech and language therapist could help with that.
All right, next question is, with ABA, are there specific techniques that do not harm the child wanting to communicate? They don't want to punish the child while they're trying to communicate.
Yep. So finding the right communication modality is going to be really helpful. And so definitely not looking at punishment. You'll see that none of those slides in there were really punishment based. I'm very focused on increasing that adaptive skill. So finding a way to communicate more effectively. So that could be whether it's functional communication training with pictures or communication devices, while also not inadvertently reinforcing the behavior by giving them access to something for an inappropriate behavior.
Are there other alternatives to ABA if families have found that method not to be effective?
So my bias on that would be that they didn't have the right ABA provider. Sorry. And I will say there are so many ABA agencies out there these days. And some of them are not as focused on incorporating families and caregivers into the treatment and assessment process. I would say you want to find somebody who's making sure that you are, as the caregiver, a component of their assessment. Because without the caregiver, they don't have that therapist doesn't have the full picture. They're just going in and doing an assessment with the child and not incorporating you. You guys know your kids so much better. So I would say that you might not have had the right ABA type of service. And there's strategies that are part of ABA that people may not consider part of ABA. So if you've heard of anything, PCIT, which is parent-child interaction therapy, it is based on the principles of behavior analysis. So PCIT is one, very focused on that parent-child interaction. So that might be a way to look at it. But again, they are technically under applied behavior analysis because of their focus.
So along those lines, for families who are really challenged with managing the behaviors, what should they ask and look for outside of their local community?
Outside of your local community. So I think
I'm trying to get like the support that they need.
yeah. So
They're
getting the
really
support that you need. You can certainly look at resources. I will tell you that Kennedy Institute, we have something called the Resource Finder, and families who are even out of state can contact the Kennedy Resource Finder, and they help them navigate to identify the types of supports and services that might be relevant for them. It's a very good resource. They have a link on our webpage for that, but the Kennedy Resource Finder is very good about helping provide that, but making sure that what types of services you're looking for could be available in your state.
Okay, great. Are there alternatives to curb aggression and reward non-aggression?
Yeah, so identifying what the reinforcers are for your child and figuring out those circumstances under which aggression is happening. So teaching them alternative ways to gain access to that reinforcement. So if the aggression is happening, and some people will say maybe it's happening out of the blue, which is always hard, right? Because we don't know what that antecedent or reinforcement was. So I always am suggesting, let's start with just increasing the amount of reinforcement for other things across the day so we can hopefully increase reinforcement in general for that child and hopefully eliminate the aggression. If there are known antecedents or consequences for the aggression, we would target that treatment to focus on those aspects.
What about for parents and like their own protection, or do they need equipment if it becomes more severe? Is there anything they can do?
Yeah, so if parents do need equipment, I do have different links for arm guards or helmets or chest protectors and all of the like that are protective equipment. Most of them are from martial arts websites or Amazon. And I do have some families who do have to wear protective equipment. Oftentimes families get very creative. And you may put on a jean jacket. A denim jacket is one that can help protect if your child's maybe scratching or grabbing or biting. That can just a normal item that you might already have. However, it's very, very hot to wear that in the summertime. There are other types of Kevlar sleeves that you can purchase and things like that.
Excellent. This was a wonderful presentation, Dr. O'Connor. We're so grateful for all the work that you've done with our families and the focus groups.